The download here, here's the small little break where he's in the ICU, and you can also see the recovery. This is very interesting. So he was actually breathing faster during the days or weeks of recovery following his admission to the ICU. And look at the patient-triggered breaths. They accelerate at the same time because he's unwell. And one could argue maybe we're not giving sufficient support and maybe we should have provided more. But this just shows you how useful these long-term downloads can be in understanding clinical circumstances. Because you might ask yourself, well, what was happening back here, or here? And you may find it's because of an upper respiratory tract infection or something. So just looked at another way, here's the nighttime use, the ICU admission, the 24-hour use, and then the introduction of the mouthpiece here. And this is why getting off the mask 24 hours a day was important, because he was already getting a breakdown of the skin on the bridge of his nose. And he was transferred from the civic campus over to the general campus, and he was still an inpatient at the general and came over for us to just ensure that his mouthpiece settings were appropriate. So here he is in our lab again. But we set this up in the ICU. Just, good on them, for allowing us to do that. So we've had experience now with a number of young people with Duchenne experiencing both nighttime ventilation and subsequently 24-hour ventilation. This is results from an analysis that I presented in Philadelphia last year, data collected by Nadia Griller, who's presently a medical student at McMaster. And the dark sort of mauve bars are the months of use of 24-hour non-invasive ventilation. So that's nighttime mask ventilation and daytime mouthpiece ventilation. This young man, I'm afraid, just recently passed away, but after roughly 140 months of 24-hour non-invasive ventilation. And you can see that the experience of many individuals on 24-hour ventilation is very extensive. And when you consider that many of these individuals would have been advised to have a tracheostomy rather than 24-hour ventilation, this has augmented their quality of life, potentially led to fewer hospitalizations. I mean, these folks come to hospital incredibly rarely, whereas readmissions to hospital with tracheostomies are very frequent. That's what the Ontario data actually shows us. So it needs to be considered, however, a tracheostomy ventilation needs to be considered when such individuals as I've just presented can no longer use a mouthpiece adequately. It's fair to say that when bulbar function is severely affected, one cannot use a mouthpiece effectively. One may be unable to swallow oropharyngeal secretions, saliva adequately, and be at increasing risk for aspiration and pneumonia. And under those circumstances, if tracheostomy is understood and supported, then by all means, such an individual should have a tracheostomy, but it should be done in an elective, controlled fashion, not in an emergency. I quote Howard Panich here, who says, you don't trach a patient, you trach a family. It is an enormous responsibility, and I'm sure there are individuals in the audience who know much better than I do how much of a responsibility it is. But there are also studies of patients who have experienced both non-invasive ventilation and tracheostomy ventilation, some who have gone from one to the other, and there are clearly patients who experience an excellent quality of life and are extremely happy with the decision that they made about having a tracheostomy. But that doesn't change the fact that when there's an alternative that's equally effective, it's much less costly and has a great benefit in terms of quality of life. So clearly the tracheostomy does provide a secure airway, I think it's fair to say that patients who are on mouthpiece ventilation, who have no respiratory reserve at all, have to be a bit, they have to have a risk-taking personality. Because if they lose that mouthpiece, if they have no access to that mouthpiece, then they could asphyxiate and die. So that there is no fixed connection to that mouthpiece. Having said that, you've seen our experience of many, many years of successful non-invasive ventilation in patients who have chosen not to have a tracheostomy, who are fully aware of the choice at hand and the inherent risks of one choice over another. So this collaborative decision-making is really important. In Ottawa, since 1993, we have not had a single Duchenne patient with a permanent tracheostomy. We have extubated that individual that I just presented to you, and we've had one young man who was trached temporarily for anaphylaxis and completely decannulated back to non-invasive ventilation and mouthpiece ventilation. So there's no doubt that there is quality of life and there's longevity associated with tracheostomy, but I think there's clearly a choice that's available. I think I've really covered these points. I often tell folks that that having a family member at home on a tracheostomy is basically 3 full-time jobs. So, just a quick mention about oxygen therapy, because people sometimes wonder about this. Oxygen is okay in the acute circumstance where it's absolutely necessary. It is should never be provided alone instead of ventilation. One should not try to correct ventilatory problems with oxygen, because that may lead to further carbon dioxide retention and serious respiratory failure. So combined with non-invasive ventilation, oxygen therapy may be necessary, particularly in the acute circumstance, but long-term oxygen therapy portends a poorer outcome than non-invasive ventilation alone. And it's really important to talk about a whole spectrum of care, including end-of-life decision-making, so that the whole decision about non-invasive ventilation itself, about invasive tracheostomy ventilation itself, and limits to care. What are the circumstances under which one would no longer feel that they're living a quality of life? Those are circumstances that are important to talk about in advance, to give folks permission to talk about, because it's often kind of a taboo subject, and there's a sense that providing non-invasive ventilation or invasive ventilation fully restores quality of life and normal longevity, and that we all know that's in fact not the case. So I would remain as optimistic as absolutely possible, but also realistic, and it's important to talk about these subjects well in advance and respect an individual's autonomy to make decisions. So, in summary, it's very important to anticipate respiratory needs before they occur and try to avoid any crises. Often decision-making in crises is much more emotional and less well thought out. Take an interventional approach, so to try to identify risk and intervene with preventive strategies. Get the technology that you need to stay away from the hospital. Try and maintain as best a quality of life as possible. So thank you very much.